Okay, so it is good to go from their side. This one. Good evening, everyone. So myself, Dr. Rijul Agarwal, I'm the orthodontic faculty at DAMS. So today we are going to take up. Sorry for the last time. It was an arbitrary end due to some network issue. Okay, so I'm going to take up the remaining part of the methods of gaining space from where it ended. Okay, so once again, good evening and thank you everyone for joining. If anyone has any doubt, you can write in the comment section and I'll be happy to answer all the doubts. Okay, so beginning with a few slides of the recap. So the topic is methods of gaining space. So what is the space required for? So what is basically the space required for in orthodontics? It is for alignment of crowded teeth. Okay, retraction of proclined teeth. So this forwardly placed teeth, if we requires them to go back, we require space for that. Correction of molar relationship, although not space is not created especially for correcting molar relationship nowadays from class 2 to class 3, we know that it's for just for canine relationship correction. Derotation or correction of rotation of anterior teeth. Leveling of curves p, as we know, flattening, for flattening the curves p requires space, and for intrusion for correction of deep pipe. So what are the methods of space creation? First is through arch expansion, which we took up in the previous lecture, proximal stripping, uprighting of tilted teeth, derotation of posterior teeth, proclination of anterior, and through extraction. We have covered all of them in the previous lectures. I'm going to start away from the serial extraction, the point at which our lecture stopped. So beginning with CL extraction. So what is CL extraction? It is a type of interceptive orthodontics. Means we know that there is a definite malocclusion which is going to develop. So by intercepting or stopping it to get worsened. So it reduces the cost of treatment. Future treatment which will be required, future orthodontic treatment will be much cheaper if required, as well as the time. Since the time is reduced, the cost in turn gets reduced, and discomfort to the patient and the time lost by the patient and the parents. Okay, since the treatment duration, the braces or the treatment which is going to be taken up for will be of less duration, it saves up time and cost as well. So it is defined as an interceptive orthodontic procedure initiated at the early mixed dentition period to avoid development of a fully matured malocclusion in the permanent dentition. So a few of the historical points. So the term was coined by Jelgren of Sweden. It was popularized by Hayes Nance, who is considered as father of serial extraction philosophy. He also termed it as planned and progressive extraction. Next, Rudolf Hertz of Switzerland, he preferred to term it as guidance of eruption. So what are the indications for serial extraction? First of all, it should be a class 1 malocclusion with a discrepancy of 5 mm or more per quadrant. These students, please note this discrepancy value is very important because it comes as a question in your exam. That is, it's approximately 10 mm in total. There should be a normal eruption sequence and skeletal growth pattern should be within normal limits. Next is localized gingival recession in lower anterior teeth, ectopic eruption of teeth, unilateral or bilateral premature loss of deciduous canines with midline shift. What are the contraindications? The discrepancy is mild to moderate, that is less than 5 mm. Class 2 to class 3 skeletal. If there is skeletal malocclusion, then we cannot go for serial extraction. Then we have to solve this problem through functional appliance. Space dentation. There is congenital absence, that is through oligodontia or anodontia. The teeth are already absent. We cannot go for extraction, more extraction of teeth. This presence of open or deep bite. Extensive caries is there involving permanent first molars which cannot be saved. So what are the various methods of extraction? First is the Tweed's method, who said the extraction pattern to be D4NC, that is deciduous first second molar, first molar followed by permanent first premolar and followed by deciduous canine. Duell's method he modified it to C, D, and 4, and he said it is usually followed in the lower arch. Next is the Nance method, similar to the Tweed method. What is important is the modified Wells method, which is in the mandibular arch there is enucleation of the premolar along with extraction of D. So at the same time, when we are extracting D, we enucleate the developing tooth bud of the permanent first premolar as well. But later on it was contraindicated by Moyes, who said that if we do not allow the eruption of 4, then what will happen? The bone in that region, as we all know, the eruption of teeth is responsible for the development of the alveolar bone in that area. So if we extract it, it will also not develop. Next, the reason for first extraction of deciduous canines is that so as to resolve the anterior crowding. Why? How it will get resolved? Because the erupting lateral will erupt more distally, improving the position of the centrals and thereby resolves the crowding in the anterior region, and also prevents the mesial migration of canines into severe malpositions. Okay, so question, so what will be the disadvantage, that is removal of premolar in the mandibular arch during serial extraction could lead to? So it could lead to lateral tongue thrust. How? Because of the presence of, as we know, tongue is a very notorious muscle. Anywhere jahan bhi space hogi, whether it's anteriorly or posteriorly, the tongue will go into that space. So due to the premature extraction of D and 4, there is an empty ditch in that space is present, and the canine still to erupt in that position, that can lead to development of lateral tongue thrust. Next, a previous year question. So if the mandibular first permanent molar erupts ectopically without much resorption of the primary second molar, then the treatment of choice is. So the lower 6 has erupted and the lower E is still to exfoliate, and on radiograph we observe that the roots of the E have not much resorbed. Then what will you do? Disking of the distal surface of primary second molar, extraction of the primary second molar, use of brass wire to move the permanent molar distally, and lastly to observe the path of eruption of the permanent molar till the exfoliation of the primary second molar. The D option is eliminated because the 6 has already erupted. So what will we do is we will somewhat move the permanent 6 distally so that it does not encroach upon the space of the erupting permanent second premolar. Okay, and on radiograph if we see that the second deciduous molar's roots are resorbed, okay, means the 5 is erupting, then we can also extract this E. But here in this question it is said that there is no or without much resorption of primary second molar. So at this stage we need to maintain the space for the eruption of E so that the 5 can erupt in its place without causing any malocclusion. So a very important previous year question, and it can be modified further according to the will of the examiner. So I hope the concept is clear. Moving ahead in methods of gaining space, if anyone has any doubt can write in the comment section. So moving ahead, that is through the topic of space maintenance. Although the topic with which I started was methods of gaining space, and space maintenance does not necessarily come in this one, but maintaining the existing space is somewhat it's a form of interceptive orthodontics only, so as to avoid the development of full-blown malocclusion. So I'm taking up this space maintenance topic under this very heading as only. So what is the cause of loss of space, okay, or cause of premature loss of teeth? There can be two factors, that is local and general factors. Local factors are trauma to the deciduous teeth, periapical pathology like a carious lesion, periodontal problems, and carious lesion. Okay, and what are the general factors? Congenital diseases like fibrous dysplasia, nutritional deficiency leading to abnormal development, endocrine problems like diabetes, genetic diseases like hypophosphatemia, and tumors. So what will happen? It will lead to loss of arch length. Why? Because as we know, the teeth have a mesial erupting tendency. So if the teeth in front of the lost teeth is lost, the teeth will get mesially migrated, leading to decrease in the arch length. So what will lead to? It will lead to the development of full-blown malocclusion, crowding, rotations, ectopic eruption, or crossbite can lead to excessive overjet and underbite or unfavorable molar relationships. So what are the important considerations in management of space? First, we need to understand the incidence of space loss. So all cases of early primary molar show some decrease in arch length. Okay, why? Because I've already told you there is mesial movement of permanent molars, whereas in anterior teeth it is a distal movement of the anterior teeth which occurs. Okay, so the amount of space lost or amount of closure depends upon various variables. So what are the variables? The tooth involved, whether it's the anterior tooth which is lost or the posterior, and the time of loss. Okay, what do you mean by time of loss? Is the amount of duration between the replacement of the succedaneous teeth. Okay, next, the time elapsed since loss, which I just told you. So the maximum amount of space closure occurs in within first 6 months of tooth loss. Very important point. And the tendency of closure is more in the maxillary arch than the mandibular arch. Thus, any kind of appliance which is fabricated for to maintain the space, it is best to fabricate this before extracting the teeth. Okay, supposedly it's a planned extraction due to any periapical pathology or carious lesion. The appliance to fabric is fabricated before extraction, so that when the extraction is done at the same appointment the appliance is placed. Okay, otherwise what will happen? Extraction is done, the patient does not report to your clinic or fails to report due to any problem. The reason for giving the appliance is lost. Okay, moving ahead. The stage of development or dental age of the patient. So, more space loss occurs if the teeth are actively erupting adjacent to the area led by premature loss of primary molars. What it means to say is that if the teeth anterior to this is developing or is in the stage of erupting, it will lead to more active space loss. Why? Because already at the time of eruption or exfoliation or exchange of teeth, there is certain tendency of amount of crowding, and जहाँ least resistant path मिलेगा, the teeth will try to get erupt from that space. Supposedly, here in this situation, this is D, E. Sorry, I'm just writing. This is the permanent first molar. This is the deciduous first, second molar, and deciduous first molar. So supposedly we extract this. So what will happen? The tendency of 5 will be to take up this path because it's the least resistant part for the teeth to get erupted. So we need to understand or look up at the stage of development of the adjacent teeth as well. Next is the amount of space closure. So loss of primary maxillary second molar, that is the upper E. 8 mm of space is lost in each quadrant. Primary mandibular second molar, that is 4 mm per quadrant. And the loss of upper and lower first primary molar, there is equal amount of space loss in both the quadrants. Next is direction of closure. So in maxillary posterior spaces, the space closed is predominantly a mesial bodily movement of the teeth, and at the same time there is mesolingual rotation tendency around the palatal root of the first permanent molars is there. And in mandibular teeth, the space loss is primarily by mesial tipping of molars or distal movement of anteriors or retroclination of teeth anterior to the space. Okay, so that means if there is a situation in which there is loss of deciduous anterior teeth. So in those cases there is no requirement for giving a space maintainer. Why? Because supposedly the A is lost, it won't there is no tendency for the surrounding deciduous incisors to get mesially migrated. Why? Because the permanent teeth have a tendency to erupt in distal direction. Okay, so the only reason for giving anterior replacement will be aesthetics, not space maintaining. So अगर option में अगर eyes option A supposedly, or there is an image based question if there in which there is missing anterior incisor, so what kind of space maintainer, what kind of appliance will you give? So you will just give appliance for establishing or correcting the aesthetics of the patient, not for maintaining any kind of space. Okay, next, the eruption timing of permanent successor. So regardless of the chronological age, the permanent teeth erupt when 3/4 of the root is developed. The eruption timing of a permanent successor can be delayed or accelerated after premature loss of a primary tooth depending upon the developmental status, the bone density of the area, nature of the primary tooth loss. Next is the amount of bone covering the non-erupting tooth. So 4 to 6 months is required for a tooth to move approximately through 1 mm of bone. That means there is the eruption velocity is approximately 71 microns per day. Okay, so while planning a space maintainer on a radiograph, we need to see the amount of bone coverage remaining over the non-erupted tooth as well. Okay, and supposedly there is an infection or periapical pathology, it can accelerate the eruption of permanent tooth due to the bone loss over it. Next is the presence of abnormal oral musculature. So in patient with strong mentalis muscle pattern along with loss of mandible primary molars or canine can lead to the collapse of the arch and distal drifting of the anterior segment. Okay, so what is the example of such habits is thumb or finger sucking. Okay, what will happen? The tongue musculature won't act, as we know from buccinator mechanism. So in thumb sucking, what will happen? The tongue will get depressed, there will be abnormal cheek muscle activity leading to the collapse of arches. Okay, and it will not only lead to development of malocclusion and crowding, and it will lead to loss of space as well. Next is congenital absence of permanent teeth. So it should be ensured through radiographically that a normal successor is present before giving a space maintainer. Basically space maintainer जिस रीजन से दे रहे हैं for the eruption of permanent teeth, if it's absent then there is no point in giving a space maintainer. Okay, so radiographically it should be evaluated. So two options should be considered after orthodontic evaluation, that is maintaining the space for a fixed replacement, or if we can allow the space to get closed by mesial migration. So what is the best space maintainer? Another important MCQ. So the best space maintainer is the already existing primary tooth. So we'll consider each of the considerations, what kind of space maintainer will be given in what situations. First, if there is loss of primary incisor, what are the common reasons for such loss? Due to traumatic avulsion or extraction due to caries or infected teeth. Okay, so if the primary canines are erupted, then there is no space loss. Okay, if they are not erupted, what will happen? As we know from ugly duckling stage, they have a tendency to erupt first mesially, then get uprighted. Okay, so if the primary canines are not erupted, then there is tendency for space loss. If they are already erupted, then there won't be any space loss. Okay, so the replacement is only for aesthetic and speech development and no, not for space maintenance. Okay, so why speech development? Because the loss of prime anterior teeth may interfere in speech as it will lead to tongue thrusting. As I've already told you, जहाँ भी खाली space होगी posterior और anterior, the tongue will protrude into that empty space. Okay, so this is the image. In case of a unilateral loss of incisor, it can lead to mesial difference of teeth. So to prevent this, a pontic can be used or a simple RPT can be given. Next situation is loss of primary canines. Okay, so in maxillary arch, it results in distally erupting lateral incisors. So unilateral loss will lead to shift in the dental midline towards the side of the loss and lingual collapse of the incisor segment, and possibly can lead to bite deepening as well. So eventually can lead to space loss for the erupting permanent canine and not for the teeth anterior to. And in mandibular arch, it results in lingual tipping of anterior with abnormal mandibular muscle activity. So in bilateral ectopic loss of canine, what you do is allow maintenance of arch symmetry but results in significant lingual reticulation and increased overjet and deepening of the overbite as well, and reduction in lower arch dimension. So here in this case we need to go for maintenance of space for the erupting permanent canine. Next is the loss of first primary molars or the D. So time of loss can be before eruption, during the eruption, or after full eruption of the first permanent molars. So in first scenario, before the eruption of the permanent first molar, what will happen? There is a tendency for a strong force to exist which pushes the second primary molar, that is the E, forward into the first primary molar space, resulting in the loss of posterior arch length within the quadrant, leading to crowding as the canines and premolar erupt in later stages. As we know, 6 erupts first and 3, 4, 5 erupts at the age of 10 to 12, between the age of 10 to 12 years of age, and permanent 6 erupts at the age of 6 to 7 years. So between those 5 years, what will happen? The 6 will get mesially drifted, leading to loss of space for the eruption of permanent canines and premolars. Next, loss of second primary molars. So before eruption, chances of permanent molar to get mesialized, leading to impaction of second premolar, and after eruption of first permanent molar, it can drift, resulting in reduced arch perimeter. So before eruption, bodily movement can occur, and after eruption, mesial tipping of the 6 can occur. In both scenarios, it will lead to crowding in the anterior region and loss of space for the eruption of second perineum. So this is just a summary and what kind of space management to be given. So missing primary tooth, that is maxillary incisors. So as I've already told you, no space maintenance is required. Okay, no consequence, exception if incisor is lost, but that too in the distal direction, not in the anterior region. So only reason to give is for aesthetics and speech development. Next is maxillary canine is lost. So a band and loop space maintainer is given. Why? So as to prevent the development of midline shift. Maxillary first molar, a band or a so as to prevent loss of arch dimension. Mandibular canine, similarly band and space loop space maintainer to prevent midline shift. Mandibular first molar, band and loop to prevent loss of arch dimension, and lastly mandibular second molar, a distal shoe so as to guide the eruption of permanent first molar into the correct position and prevent the loss of arch dimension. So what are the requirements of space maintainer? It maintains the space created by the loss of primary tooth. It should be passive in nature, not active. If it becomes active, it becomes space regainer. It should not interfere with the eruption of occluding teeth and permanent successors, prevent supereruption of teeth opposing the space. It should not impose or excessive stress on the adjacent teeth, not interfere with speech, mastication, or functional movement of mandible. Simple. It should be simple to construct, easy to maintain, strong, durable, improve aesthetics, and should be easily cleanable, and should not restrict the normal growth and function of the jaws. So, what is the classification? According to Hitchcock, it can be removable or fixed or semi-fixed. It can be with or without band, functional or non-functional. Functional means presence of tooth or crown on it, so that it can aid in the function. That is, the major function of space maintainer at this time is chewing, and non-functional like a banded one without the absence of a crown or tooth on it. It can be active or passive. Active one becomes a space regainer and a passive is a space maintainer, and it can be a combination of the above as well. So what are the examples? Succedaneous permanent teeth are free to erupt into the oral cavity. Disadvantages: instrumentation and tedious to construct. Bands are more prone to caries and decalcification beneath them, and supra-eruption of opposing tooth can also take place because of the absence of a coverage on the occlusal surface. So what are the components? It has a band, loop, and a soldered joint. Various steps are constructing a band, impression, loop fabrication, soldering, polishing, and cementation. Okay, not important for your MCQ point of view. What is important are the band material and the dimension. So for the anterior teeth, it's 0.003 into 0.125 into 2 inch. For premolars, it is 0.004. From primary molars, it's 0.05, and permanent molars is 0.06. Okay, and what are the basics tenets of the loop construction? It should be parallel to the edentulous slits, contact the abutment tooth below the contact point. The dimension of the loop, this dimension should be approximately 8 mm so as to allow the eruption of the permanent successor between them. Okay, and stainless steel is usually soldered by silver solder, that is at this joints. And next is this is the cementage. Now coming to the various types of space maintainers. First is the band and loop. It's a fixed type used for either maxillary or mandibular, can be unilateral to bilateral, and given in the premature loss of primary molar cases. Indications I have already discussed in the tabular form, that is premature loss of primary first molar in the primary dentation of the primary maxillary first molar in the transitional dentation. Premature loss of primary second molar as the permanent first molar is erupted. Bilateral loss, or sometimes given in case of premature loss of primary canine as well. Contraindication: the occlusion is severely crowded and exhibits a marked space loss. There is high caries activity in the mouth, and replacement of primary anterior teeth is there. It can be modified in the functional form as well by giving a crown instead of a band. Okay, example in the case of post-pulp therapy of the abutment tooth. And next is the band and bar type. Both the abutment teeth are banded and a bar is placed between them. Next is a reverse band and loop space maintainer is there, in which instead the distal abutment tooth cannot be banded, so a mesial abutment tooth or the tooth opposite to it is banded, and given when the second primary molar has been lost and distal aspect of the permanent first molar has not fully erupted, has a large pericornal flap. Thus the band is placed on the primary first molar. Next is modification is the band and loop appliance with the occlusal rest. So it is given to overcome the disadvantage of appliance slipping gingivally, that is to avoid the tipping of the banded tooth. Next is a bonded space maintainer, in which there is no band, just a loop is there which is directly bonded on the tooth with the help of composite resin. Next is the lingual arch. It's a mandibular fixed bilateral non-functional passive type of space maintaining appliance. Indications: bilateral loss of molars are there after the eruption of permanent incisors in the lower arch. Okay, why the permanent incisors should be fully erupted? Because it interferes the eruption of permanent incisors. Okay, so this is the image in which multiple carious teeth need to be extracted and a lingual arch is placed. Contraindications are before eruption of permanent mandibular incisors. Advantage is it's a good source of anchorage, prevents measure is to maintain the arch perimeter by preventing both mesial and lingual drifting of the molar tooth and cause lingual collapse of the anterior teeth. Preserves the space created by multiple loss of primary mandibular molars. It's less bulky and removable acrylic type of space maintainer. Maintains the aesthetic arch form as it is not easily displaced. Allows the eruption of permanent teeth without interference and it's comfortable to the patient. The disadvantage is decalcification of the band and material and the teeth. The arch wire can become embedded in the soft tissue, which seems to occur more often in patients with poor oral hygiene. So this is the image in which this arch wire is embedded in the soft tissue. The wire can become distorted by the presence of masticatory forces. What are the modification? It can be semi-fixed or removable type of lingual arch. The band is fixed and the arch wire is removable. It can be semi-fixed by welding into the molar tube on one or each band of the lingual aspect. Another modification is the presence of canine spurs on the lingual arch at the distal end of the canines, so prevents the distal collapse of the anterior. So this is the canine spur. So what will do? It will prevent the distal migration of the anterior teeth. Looped lingual arch, one or two U-loops are incorporated to make it active. So this is the presence of loops. What we can do is, this is the loops. So if we open this loop, what will happen? It will exert force on the posterior teeth to go distally, and at the same time this wire component will force this teeth to go anteriorly. So it will start to open up space here. So helps in distalizing the molar and proclination of the collapsed incisors. Next is the Nance palatal arch space maintainer. It's a maxillary fixed bilateral non-functional passive appliance that does not contact the anterior teeth. So there is a presence of this acrylic button which contact the palatal tissue and provides resistance to the anterior movement of posterior teeth in the horizontal direction. Indications. So it maintains the position of the first permanent maxillary molars when there is bilateral or premature loss of teeth in front of it. Contraindications are presence of any palatal lesion or either of the first permanent molar have not erupted. Advantage, it stabilizes the arch. Disadvantages, it irritates the palatal tissue and cannot be given in patients allergic to acrylic. Next is palatal tissue hypertrophy. The button can get embedded in the soft tissue, likewise in the lingual arch as well, and palatal inflammation and pain can occur. Next is the transpalatal holding arch. So it's also known as Gaucherian arch. Why? Because it was given by a scientist named as Gaucherian. So it's also known as Gaucherian arch. So it's a unilateral fixed passive and non-functional maxillary appliance. Indication: when one side of the arch is intact but several primary teeth are missing contralaterally, as well as other molar movements are needed. Contraindications is in cases when there is bilateral missing case, as both permanent molars can shift mesially simultaneously. So unlike in Nance arch, when there is presence of acrylic button, there is just a palatal stabilizing wire. So if there is bilateral loss, what will happen? Both the molars can move in the mesial direction. So one side the teeth should be there, it should be a unilateral loss only. In bilateral cases we need to go for Nance holding arch. Can be used in multiple unilateral losses and can be used for expansion as well. How? This loop can be opened up so as to aid in expansion and correction of this rotation of teeth as well. Next is the distal shoe appliance, also called as intra-alveolar appliance and a eruption guiding appliance. It's a unilateral, fixed, non-functional and a passive space maintainer. It's an intra-alveolar appliance which a portion of the appliance extends inside the alveolus. So what are the indications? In cases of primary deciduous second molar loss prior to the eruption of first permanent molar, ectopic eruption of the first permanent molars, and use only when one tooth is lost on one quadrant as the strength of the appliance is limited. Contraindication: the abutment is inadequate due to loss of multiple teeth, their hygiene is poor, missing permanent first molar, lack of patient and parent cooperation, the patient is medically compromised like congenital diseases, kidney problem, juvenile diabetes, or history of rheumatic fever and hemophilia. Why? Because the appliance embeds inside the gingival tissue. So we're going to discuss a bit about its construction as well. So an impression is made and a crown or band is placed. On the impression, a cast is prepared. The width of the horizontal and vertical arm of the distal shoe is measured. Now the IOP is taken to see the distance between the alveolar surface and the mesial marginal ridge of the first permanent molar, so as to determine the depth of the intraalveolar extension. The depth is such that it should extend 1 mm below the mesial marginal ridge of the erupting first permanent molar, which is measured from the radiogram. Now the extraction, if planned, should be done just before the cementation to minimize the risk of mesial migration of the first permanent molar. The band and crown is tried after extraction and the IOP is taken to confirm the position of the intraalveolar extension. Sometimes a prefabricated crown along with distal shoe extension is also used so as to provide a functional need for it. Next is this appliance that is known as Gropper appliance. This is a very important appliance which came in your INI AIMS exam back in 2018. It was given by Jasmine and Gropper in 1984. The main objectives I've already told you in the anterior region is aesthetics, mastication and speech development. So basically it's the anterior aesthetic space maintainer. Anterior aesthetic teeth replacement. So this is the banded appliance which is fixed and on which band the teeth are acrylic teeth are attached. Next is the removable space maintainer. It's like a partial denture, can be removed or reinserted by the patient. It can be functional or non-functional. Non-functional, in which a simple just acrylic plate is given. Functional, in which teeth are attached for patient to chew. So what are the indications? There is loss of multiple teeth unilaterally, either in the anterior or posterior region. Absence of abutment teeth are there when the space maintenance requirement is for a short period of time. And contraindication is uncooperative patient and patient allergic to acrylic. What is the advantage of removable one? It's easily cleansable, both the appliance and the teeth. It maintains. Is it 1 mm or 1.5? What to choose, sir? Can you tell me in which you're asking about distal shoe? So Bhavna, it's 1 mm below the mesial marginal ridge of the first permanent molar in distal shoe. If you're asking about the same. So what are the advantages of a removable space maintainer? Okay, it can be worn part-time allowing the free blood circulation, although it's not indicated for a space maintainer to be worn part-time. As I've already told you, the space loss occurs quite quickly. Can be made aesthetically desirable. So it's 1 mm below the mesial marginal ridge of the first permanent molar. It facilitates chewing and speaking when it is made functional. It stimulates the eruption of permanent teeth, keep the tongue in position, and band construction is not necessary, reducing the chair side time. If there is any confusion with the data you have read somewhere else, just kindly tell me. I'll check it once again. So according to me, it's 1 mm below the mesial marginal ridge. Pedo में 1 to 1.5 mm लिखा है. I'll just check it once again. What I have read and what we have done studied in orthodontic literature, it's 1 mm. I'll again check with it, okay, and get back to you. Disadvantage: it can be lost or broken because, as we all know, acrylic plate and a child, it's very difficult for him to wear that. Cooperation with the removal appliance is very important and can irritate the soft tissues as well. Next, some of the newer kind of space maintainer. It is a EZ space maintainer. It's an adjustable bondable space maintainer which can be directly bonded during one in-office visit. It's a fixed appliance which provides easy maintenance of the mesodistal dimension of any lost disfigured teeth on an adjustable appliance by using the nickel titanium coil included to regain some lost space. So this is the EZ appliance. It's just bonded to the anterior teeth and a posterior teeth with the presence of a nitride coil spring here. So what we need to do is, if we need to regain some space as well, we just need to adjust this stopper so it will exert forces from it and open up the space. Okay. Next is this. This is the intraoral image of a EZ space maintainer paste. These are prefabricated. Simple, easy, directly bonded appliance, more hygienic, aesthetic and less time consuming, and fixed appliance with adjustable options is there. Next is this Ribond type space maintainer. It's spelled and written same, Ribond. It's a glass fiber reinforced composite resin introduced in the year 1992. So since it's glass fiber reinforced, the strength is equivalent to that of a stainless steel. The advantage is biocompatible and its aesthetic material made from high strength polyethylene fibers. Advantage is easy to adhere to the dental contour, fast technique of application and a good strength is there. The cooperation required from the patient is minimal, takes little time and is thus readily accepted by the patient. So there is no lag work, same appointment, you just need to bond this thing like this. It's available commercially like this in various dimensions. You just need to bond it like this and the work is done. Okay, so this is the newer kind of space maintainer. So this is the unique crossing lock stitch leaf Leno weave pattern of Ribond fibers which is present. So just remember this pattern of the fibers. So that's it from my side on topic space maintainer. The important thing is the indications and the where to give and where not to give space maintainers. Okay, so you just need to know that very much. Okay, and lastly, which type of space maintainer, I think you'll be able to do that very easily. The most important at this level, at graduation level, is where to give and not to give space maintainer, because you get a case history based or image based questions on these scenarios. Okay, so if anyone has any doubt, you can just write to me and you know where to reach us. We'll be very happy to answer. So till that time, keep studying. I'll just close the session now. Okay, and just wait for a minute or two if anyone has any doubt, otherwise I'll close it. Okay, so thank you everyone for your time. Thank you for joining. I'll just close it.